Welcome to another episode of What Brings You In Today.
I'm Erica Bennett.
And I'm Taylor Fisher.
And we want to start off first by thanking all of our listeners for tuning in to the What Brings You In Today podcast.
And if there's any topics you would like us to talk about, you can submit those on our website at sgmc.org/podcast.
Also, be sure to leave us a review. Today, we are here with Dr. Jeff Anucha, and he's a gastroenterologist at SGMC Health. So, Dr. Anucha, what brings you in today?
I'm here to talk about all things GI.
All right. And, GI, I feel like is always a something that most people don't really want to talk about, right?
It can be uncomfortable for a lot of reasons.
Mm-hmm.
So first, let's just hear a little bit about your journey to become a gastroenterologist and kind of how you got to SGMC Health.
Okay, so my journey started with medical school. I went to medical school in Ghana, and when I was in medical school, that's when I started appreciating GI more, especially with the disease processes involved in the GI tract, as well as the pathology and the physiology involved as well. And then after medical school, I became a sort of like a hospitalist in Ghana, West Africa. And then subsequently, I took my licensing exam to move over to the U.S. And in the U.S., I started my medical residency, internal medicine residency in New York, Harlem Hospital. And then in Harlem during my residency, that's when I began to also appreciate GI more because I was able to observe procedures, GI procedures, colonoscopies, upper endoscopies, and ERCPs. And I was like, wow, this is what I want to do when I'm done with medicine training. And so subsequently, I was done with my internal medicine residency. I became a chief resident for 1 year. And that was during COVID. And then after COVID and after the chief residency here, I became a GI fellow. And then subsequently, after I was done with my GI fellowship, or during my training, SGMC Health reached out to me, gave me a phone call. I came down. We loved what we saw. We loved the neighborhood. We loved the environment. We loved the city. And that's where we are now.
Awesome.
And the rest is history.
Awesome.
We're definitely glad that you're here because I didn't even realize until I, started, knowing some people that needed to see a gastroenterologist, how important they are and how many different things that you guys deal with. And we're really glad to have both you and Dr. Mendal and then all of our other affiliated gastroenterologists.
For sure. It certainly seems like a rare find to get gastroenterologists in rural Georgia, rural places.
Yeah.
So tell us a little bit about what you see in your practice. Or let's start maybe with when someone would come to see you, what kind of issues might they have?
So the most common complaints we get to see in the GI clinic is acid reflux, unintentional weight loss sometimes, and we get chronic constipation, chronic diarrhea, and then occasionally we get some bleeding as well, mostly rectal bleeding. Those are the most common ones we get.
Do you have to be referred to a gastroenterologist from primary care?
Yeah, because it's a specialty. It has to be referred by a primary care physician.
Okay, so again, that common theme that we see when we talk to all of our specialists, it's so important to make sure that you have a primary care physician so that they can get you access and help guide you to the specialist when you're having these concerns.
That's right.
Yes, definitely. My dad had to see one of our gastroenterologists, and I'm not sure if it was you or Dr. Mendal, but he got diagnosed with AVMs.
Okay.
So that was something that I had never encountered. And it's like there's all these different things you don't think about with your digestive system that could be causing you issues. So, I mean, can we just talk a little bit about
gut health?
Is
there anything that you can proactively?
Yes, that's where I was going.
Proactively do to decrease your odds of having to come see you?
Okay. First of all, it's so gut health. There are three things that are very important for gut health: fiber, physical exercise, and water. So fiber, you need to take in more fruits and vegetables. Essentially, the ideal diet is a Mediterranean diet that consists of fiber, essentially fruits and vegetables, healthy oils such as avocado oil, what was the other one? There's so many of them. Avocado oil, peanut oil, and coconut oil, those kind of oils. And then you also have the The other one I was thinking about is whole grains. So these are the things that consist of in the Mediterranean diet. And then physical exercise, you have to at least 30 minutes to 30 minutes to an hour, at least 3 times a week. This will help to stimulate the gut, because what we've come to notice is that patients who are very sedentary the GI system tends to slow down as you slow down, and then patients come along with a lot of constipation. And we also try to tell patients to drink more water, at least 8 glasses a day if they can. But water is essential to life, so it's also essential to your GI tract to get things moving as well. So water, fiber, and exercise.
That's interesting. I would definitely think the water and the fiber, but the exercise component affecting your gut health is very fascinating.
Well, I've noticed that personally. Like if you don't go to the gym or exercise for a while and then you go back, there's definitely movement.
Not necessarily just going to the gym. You can just go for a brisk walk around the neighborhood.
Just being active.
Exercise after you've been, sedentary for a while. I've noticed. I'm like, okay, this is different.
Yeah. The more you move, the more the gut moves. And that's why when you fall asleep, the gut falls asleep as well. So the more you move, the more the gut moves.
Wow.
And that's what we prescribe to patients with chronic constipation. You just got to move more, you got to exercise more, get active.
Well, and then also if you're more active, you're probably drinking more water.
Yeah.
And then you are also likely probably to eat a little bit healthier. I know I am. When I have a better routine, I tend to eat better. And then, that's good.
Yeah.
What about probiotics? And can we talk about how important, the kind of biome of your gut is? So
probiotics, you can get them from fermented food products like yogurt, kefir, and then sauerkraut as well. Probiotics provide a good balance to the microorganisms that exist as a microbiome in your GI tract. And so when we talk about the microbiome or the microorganisms in your GI tract, we're talking about the good bacteria, the good fungi, the good viruses that exist within your GI tract. And we always try to tell patients to be on probiotics because this will help to allow the proliferation, the growth of the good bacteria in your gut, and this will help with the gut health.
Especially if you've had to take antibiotics frequently, which is something I've been told by physicians is that then you're at risk for killing the good bacteria as well. Yeah. So it's good to balance it out with the, other supplements.
Yeah, that's correct. Yeah.
That's so interesting.
What about food allergies and
food insensitivities?
Yes, insensitivities, I guess is the better term. I feel like we're seeing a lot more of that, or hearing at least
gluten intolerance,
people are having a lot more of that.
Yeah.
Are they just more aware of it, or do we think there's something? I mean, our gut is just reacting differently based on the stuff that's in our food, or what are your thoughts on that?
So there are 2 things. There's food intolerances, and then there's food allergy. With the food allergy, you are allergic to the food. So you get the whole hives, you get the facial puffiness, the redness, and the difficulty swallowing and breathing. So essentially, food allergy, you get an immune response. But with food intolerance, it's kind of like lactose intolerance. So you're not able to break it down. So you get your bloating, your diarrhea, and your abdominal discomfort. So that's where we get with the food intolerance. You essentially don't have an immune response, but you don't necessarily, in some cases, don't have the enzymes to break down certain food products. And that is where we try to do an elimination diet. If you're not having the immune response, you definitely have the intolerance. So what we do is we try to eliminate certain foods. In our clinic, we have a sheet of paper where we tell them these are the things that are likely causing your symptoms. Try to eliminate them over the next 6 weeks and see how you feel. And then patients usually come back feeling, this actually worked for me.
Yeah.
I think that's so interesting. My little nephew had a milk or lactose intolerance when he was born, but I think they've slowly been able to reintroduce it as he's gotten older. And it's just so crazy how your stomach, your gut responds to different things like that.
Yeah. 'Cause, yeah. 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 Sometimes the enzymes aren't present, and eventually they do form.
So, as far as because I was like, well, is there any test that you can tell about that? Well, the elimination process, that can be a long and lengthy kind of thing to figure out. But for preventative screenings, so we'll talk about maybe the most common one that everybody knows or has heard about is the colonoscopy.
Oh, dear.
Everyone's favorite topic.
Yeah,
Right, I know. So tell us who qualifies for that currently. I know sometimes it can change depending, but who qualifies and then why is it so important to get that screening?
So the screening is for both average risk and for high risk patients. So for average risk patients, meaning that they don't have a personal history of colon cancer and they don't have a family history of colon cancer. Family history that we're most concerned about is colon cancer in a first degree relative, meaning a sibling or a parent. And these are the patients who are high risk for colon cancer. Average risks don't have any of this risk at all. So typically for average risk patients, we start screening at age 45, and then we do it subsequently every 10 years if the first scope was normal. So for high risk patients, they might be required to come in 10 years earlier than most average risk patients because of their high risk.
And what does the colonoscopy, what is it looking for? What are you
looking for? Yeah. So with the colonoscopy, we are looking for polyps that could become cancerous. We're looking for any abnormal tissue in the lining of the colon that needs to be removed. We're also looking for colon cancer because some patients come in with rectal bleeding, and then when we go in, there's a mass sitting in the colon that needs to be biopsied, and then the pathologist will give us a final diagnosis, and then we refer the patient to a surgeon to have that mass taken out.
Are we seeing more colon cancer or less? More?
We're seeing more colon cancer because the screening is slowly going up, and patients don't necessarily need to do just a colonoscopy. Some patients are very uncomfortable with the colonoscopy, but if they're average risk, we can offer them, especially with the primary care, they can offer them stool-based testing. And just recently, the FDA just approved blood-based testing for colon cancer screening. So that is also another option for patients. So with that driving up our screening rates, we're seeing more colon cancer, detecting more colon cancers, especially in younger patients. And I think that has a lot to do with diets right now. Because a lot of our diet is moving towards more processed food, more saturated fats, and that is also increasing the mutations that are causing the colon cancer to form in the colon.
Wow. I hadn't thought about that. That's really interesting. Because I know we've heard about, the Cologuard. You see the commercial. So that's the stool-based screening.
Stool-based test and detects abnormal DNA shed by the cancer cells into the stool.
And then now they have a blood test
And now they have a blood test as well,
Well, hopefully, yes, that will make more people want to do it since it's a less invasive
So the
procedure.
stool-based and the blood-based will only be for average risk patients. Because if you're high risk because you have a parent or a sibling, then automatically you should just be getting colonoscopies every so often.
And the importance of finding it early versus later.
Yeah.
What do we see with that?
So if we find cancer early, meaning it's in the early stages, we are able to remove it without you undergoing further chemo or radiotherapy, because just taking out that part of the colon is curative if found early. So subsequently, you obviously will have to get colonoscopies every 1 to 3 to 5 years because you're now considered high risk. So detection is key, prevention is key, but you also have to come in early as well.
And do you ever find it and patients were having no other issues?
Yeah. Some patients come in with anemia. Some patients come in for just routine screening because their loved ones were like, it's your time to get a colonoscopy. And then they just say, okay, fine, I show up, and then we detect cancer, and they are shocked. So, yeah.
Wow. Yeah, I'm sure it takes a little nudging from somebody, a loved one. Nobody is just like,
a wife.
hey, I'm over my colonoscopy. Let me go get that scheduled, right?
Yeah.
Is it more? Have you seen if it's more common in men or women? As far as colon cancer is concerned,
I think it's balanced. It's balanced. I mean, I have seen quite a bit of men recently, but I've also detected in women as well. So I think it's balanced in my experience.
I was just curious.
Okay.
What kind of changes have you seen throughout your career, or just in the field in general, that how treatments and detection and stuff have evolved?
Okay. So in the field of GI, a lot of advances have been made. I know when I was in residency and then fellowship, there were a lot of drug companies coming up with biologic drugs that we use to treat ulcerative colitis and Crohn's disease. I know it used to be just a Remicade and then the Vito and TVO. Those are the drugs that usually were marketed back then. But now there are probably like 50 different drugs right now out in the market to treat patients with ulcerative colitis and Crohn's disease. And then there's also the fact that the FDA just approved the two tests for colon cancer screening through blood. And then there's also the use of weight loss drugs now. As for the obese patients, we used to always have to refer them to a bariatric surgeon for weight loss surgery. Now they are getting placed on these drugs and losing a tremendous amount of weight. So that's a lot of advancements. And then also with procedures as well. A lot of advanced GI doctors are now doing weight loss procedures through an endoscope as well. And also doing minimally invasive surgery so that patients don't necessarily need to get their colon taken out, for example. The doctors can go in and then take out that area minimally without major surgery involved. So yeah, a lot of advances are being made and are being made as we speak.
What is the impact? I've heard a little bit about this. So if people are using the weight loss drugs like the Ozempic or the
Wegovy.
Yes, and so it slows down your digestive tract. So what are your you have to be very careful when you're on those, and that's also another important reason you should probably do that under the care of a primary care versus there's a lot of companies I've seen like you can buy it online and things like that. But tell us how that impacts the gut and just what maybe people should kind of be aware of. So
yeah, the drug is definitely it not only makes you lose weight, it also improves your reduces mortality from cardiovascular complications. But yes, it affects the GI tract by slowing things down. Some patients get very bad constipation on it, and then eventually just have to stop the drug. And some patients get worsening reflux. And so these two complications for some patients, especially the ones that causes abdominal pain in some patients as well. So these three things make some patients fall off the drug. So we always offer other options such as weight loss surgery. So it's always an option for patients. Everybody's different. Everybody's responds differently to drugs. So we just offer patients, if this drug doesn't work for you, we always have weight loss surgery, which is readily available and has good outcomes.
Yeah. We actually just welcomed a bariatric surgeon, so we're in the stages of getting that program up and going. So that's awesome for our community. And then this is the one I wanted to ask. You always hear people say, trust your gut. And, they say that your gut can, you can sense things through your gut. What do you know about that, if anything? Is it an old wives' tale? But, you can get a bad feeling in your gut about things. Yeah. What do you got to say about that? You're the true gut doctor, so.
So, yeah, trust your gut. Essentially, trust your gut means that you know your body.
Yeah.
It's a way of saying that you know your body, and that when you sense something is going wrong with your body, you might experience a weight loss, you're noticing that your trousers are falling off, or your trousers are getting wider, or you're getting more nauseous than usual, or you're losing appetite. So essentially, trust your gut just means you know your body, you're sensing something is different about what's going on with your body, and you just have to report, seek medical attention, speak to a primary care physician.
And actually tell your primary care physician.
Yes.
Don't just go and say, oh, everything's fine.
Yeah, pretty much.
I think your gut is really, it's kind of like the center of your body. Yeah. Like for people that deal with anxiety, I deal with anxiety. And I don't know if it's, technically called like gut anxiety, digestive anxiety. But I do, when I start to feel anxious, I feel it in my
your gut,
more
Yeah.
than any other place. And that's how I truly know that I am having anxiety.
Yeah.
So there's a two-way communication between the gut and the brain. And so any patient who comes in with symptoms of irritable bowel syndrome, I always try to delve deeper into their mental health, asking about anxiety and depression, because of this two-way pathway, patients with underlying anxiety and depression are prone to developing irritable bowel, especially in patients with anxiety. They tend to get more diarrhea because the brain is sending more signals to the gut, and that makes the bowel more irritable, and they go to the bathroom more often.
Yeah. I think in children especially too,
Yeah.
like if they say like, oh, I'm sick, I don't feel like going to school, and then you're like, well, let's dig into that. Maybe they just
yeah.
are nervous about
Yes,
something,
exactly.
a test, or
I've heard it's
being
kind
bullied
of
or
like
something.
a kind of caveman response. You're like
Flight or
scared, and
fight,
your body's
yeah.
just saying evacuate.
Yeah.
Let's evacuate so we can run.
Flight or fight reflex, yeah.
I just think it's so interesting how so many things are connected to your mental health
Yeah.
and your brain, even as so far as your gut.
Yeah.
I feel like it all goes back to mental health.
That's correct.
And what would you say to patients who are nervous about coming to see you or any gastroenterologist? Because I'm sure it's scary. Like, oh,
Yeah, it's. I understand their nervousness, but I always try to put them at ease that they are in the right place. It's better to know what's going on than to continue to live in ignorance, because something terrible might be going on and you decide to ignore it and then it becomes too late. So coming in to see us early will allow us to start the detection process early enough, and then we can fix the issue, and then you can go on to live a healthy, normal life.
Do you see a lot of patients that like ignore things for a long amount of time, and then
Yeah.
they finally come to you and you fix it, and they're like, "Man, I wish I would have done this earlier." you know?
Yes, especially with men.
Yes.
Yeah, I was going to say, I'm just going to throw my dad under the bus here for a minute.
I don't know. I think it's a trend we see just in general, especially in South Georgia. I mean, I think it's getting better
Yeah.
as we're getting more education
Yes.
out there. We're
Yeah.
having more specialists
That's
here that
correct.
people are able to talk to and get to know. But a lot of people do have like the white coat syndrome where they're just nervous about going
I feel
to
like
see
I
the
have
doctor.
a little bit of that with my anxiety. I've gotten more comfortable since I've worked here,
Okay.
but still, when I go to the doctor, or I had to get my flu shot the other day, and I was so nervous the whole entire time. But again, it's nothing I can control. My stomach is just like, this
Yeah.
isn't good.
I think education is helpful, and
Yeah.
that's one reason we wanted to sit down with you today, and also to get to know you, because you are very friendly, and you make me feel at ease. If I needed anything, I would feel comfortable for that. But we appreciate you. We appreciate you being dedicated to this field
Thank you.
Can
and
we
helping
talk
take care of
about
us.
one more thing that no one wants to talk about,
What?
even more
I'm
than
nervous.
colonoscopies? Hemorrhoids.
Oh goodness.
I know. It's not the best thing to talk about, but it's so common, right?
Yeah, it is.
So how can people prevent these?
So
Is there a way?
water, fiber, and exercise.
It's the same exact thing.
Exactly. So if you don't strain as much, if you're not constipated as often, then I mean, definitely some women who get pregnant
Right.
they have
'Cause
hemorrhoids.
sometimes
That's
it can't
unavoidable.
control
Is
it.
that
yeah.
more of like a hormone type thing that's causing it, or
It's
is
more
it
of a
from
pressure.
the pressure from the baby?
on the pelvic.
Okay.
Yeah, there's a lot of pressure
I didn't know
down
if it was
there.
like a hormonal imbalance
Yeah.
that made it
Yeah.
susceptible, but just that baby weighing down on
Yes, sitting on a
weighing
lot
down
of
on you.
vessels. Yeah.
Well, nobody wants to talk about or admit that they have
Yeah.
hemorrhoids.
It's definitely
And then they
not
can go
even-
away, I guess, over time. They can go away. But then if they are not going away,
Yeah,
Right,
especially if
when-
they're bleeding, you can come see us. If you come in with bleeding, we have to do a colonoscopy. Even though we know it's hemorrhoids, we just want to make sure there's nothing else in the colon. And then we also have techniques that we use to treat the hemorrhoids. If we can't, we can always refer to a surgeon who can take care of especially the external hemorrhoids. Surgeons can be able to take it out.
So you don't just have to suffer.
No, you don't have to.
And how long should someone, be dealing with this?
Before they come see you.
Yeah, before they decide to come. I mean, how long is a normal period when they should go away?
You should come in when you feel it's still persistent, especially with persistent bleeding. You should definitely come in because it's not just hemorrhoids. Like I said, it could be something else. So if you see bleeding and it's still persistent, even after a week, you should probably talk to your primary and then they'll refer you to us.
Okay, another thing, that regularity. Like, I know some people
These
say
are the
that
things people want to talk about. They don't
like
want
a bowel
to, but
movement
they do.
like once a week or something like that. How often should you have a bowel? What is a healthy
bowel movement? Ideally once a day.
Once a day, okay.
Yeah, once a day is ideal.
Okay.
But some patients, everybody's different. Some people go once a day, some people go 3 times a day, some people go once every 3 days, but once a week is a little extreme.
Yeah. And then what is the deal with people that go on vacation and they don't have a bowel movement while they're on vacation? You know what I mean? Because they're not comfortable.
Yeah, they're not comfortable. Yeah.
That's not me, but I just do know of several people when they're on vacation or out of their normal realm, they can't
It goes back to your gut and your mental health.
Is that mental?
Yeah, pretty much.
You're I'm not comfortable
You're
here.
not comfortable.
I can't go here.
Yeah.
I mean, I've struggled with that myself. And then you're
My son will not use the bathroom, number 2, at school.
Oh.
Not this one, in the room, the other one. But he'll hold it till the very, which I'm like, that's probably not healthy either. But it's just interesting that
yes, it's just the
a
brain.
psyche.
Yeah, they're comfortable at home. That's where I want to do my business. Yeah, that's pretty much what happens.
I mean, I think these are the hard-hitting topics people want to know about.
Right?
Everybody goes. You can't be ashamed to talk about it. You do need to drink your water. I'm guilty of not drinking enough water sometimes.
Lately, I've been bad with just having so much of all the different things that have happened around our community lately, and you kind of get off that routine of drinking water. But it is nice to know that it really is that basic to kind of keep your gut in check.
That's right.
So good. I can handle that. I can handle those things.
I think so. I think that this has been a really good conversation.
Yeah. Mm-hmm. Anything else you want to share with us? Anything that, any common misconceptions or common questions that you get asked that we haven't already covered that you'd like to share with the public, or we've done a pretty good job of?
Yeah, I think we've covered a lot. I think we've covered a lot.
All right. Well, very good. Well, we just want to thank you. We can wrap it up now, and then if we get any hard-hitting other questions, we'll bring you back.
You have my number. I'll be here.
Okay. All right. All right. Well,
thank you for joining us. Thank you, everyone, for joining us today. And if you have any questions for Dr. Anucha or any of our other physicians or providers, please submit them at sgmc.org, and we'll see you next time.
Thank you.
Thank you.